Hello and welcome to today's webinar. My name is Felicity Thow and I'm a physiotherapist and the campaign manager for the Flippin Pain team. Today I'm talking to Associate Professor Tasha Stanton in the third and final instalment of our Flippin Arthritis series. This is a pre-recorded event where I'll be putting the questions to Tasha that we didn't get to in parts 1 and 2, and we'll also have time at the end for Tasha to talk us through some of her most current research, so stay tuned. Flippin Pain is a public health campaign aimed at flipping how we think about, talk about, and treat persistent pain and related conditions like arthritis with people affected by it. We share information with people affected by it and with healthcare professionals who support them. Our Flippin Arthritis series has been funded by Hayward, Middleton, and Rochdale Integrated Care Partnership for people affected by arthritis across Greater Manchester, but all are welcome to join. If you've not seen parts 1 and 2, you can find them now on the events page of our website or by searching for Flippin Arthritis on YouTube. So I'm delighted, as I say, to welcome Associate Professor Tasha Stanton, all the way from the University of South Australia, to join us today. Tasha, let's launch into some questions.
Yeah, well, thanks so much for having me. I'm always excited to get a chance to chat and dig into the details.
Excellent. No, we're pleased to have you. It's brilliant. So let me get my questions sheet ready here. So as we say, we talked about a lot of this in the first two webinars. So as I say, if you're just watching this for the first time, do go back and watch parts 1 and 2 before this. But let's dig a bit deeper because there were some common themes that emerged. One of the things that came up and we had asked again in the interim was, it's quite scary to start activity, right? It's quite scary to start activity when you are fit and well, let alone when you live with persistent pain, or even, layer that with depression or a rheumatoid arthritis or inflammatory problem, lymphedema. There was a strong ask for, I guess, reassurance that is it okay to start anywhere? Like, is there a point where it's not worth it, or is there a point where you would recommend people start?
Yeah, so I think this is actually a really important message that it's not just things like running or doing really, hard, vigorous effort activity that's important to health, to osteoarthritis, but actually lower levels of exercise and doing anything, increasing anything is actually really critical and can play an important role. Because the thing is if you're not doing very much right now, thinking about starting something huge and a lot of activity, that's way too much. And that's just not doable. And we actually risk the chance of potentially making ourselves worse or less likely to want to keep up with that, certainly, because it won't be very fun. But so starting slow and starting to really slowly kind of increase that over time is a really key aspect. But it's also really important to talk about the evidence that's there that suggests that, lower levels of exercise is still really important. So there's been some studies that have been done that have looked at walking programs, for example, in people with knee osteoarthritis. And these have shown that when you do kind of walking for fitness, which is kind of titrated or set to the level that that person's starting at, what they see is that people get improvements in their function. So they're, first of all, better able to walk. They can walk longer distances with less pain. And these improvements that they have in function, it's not coming at worsening symptoms of pain in the joint. So it's sort of suggesting that, even something like walking at the level that you're used to and slowly but surely increasing kind of the time and the distance that you do that can have really positive benefits to your functional status, but also possibly to pain. There's also been work where they follow like a really big group of people over time and they say, okay, how much activity they're doing at the start predict how they go later on. So, for example, there was a study that was looking at nearly 2,000 different people, and they looked at what happens to how much they're walking right now at your baseline measure, and does that predict their function later on? And they found that it did, so that every additional about 1,000 steps per day, that was associated in reducing functional limitations. Or to flip that the other way around, increasing numbers of walking steps per day by about 1,000 was actually associated with better function. And what they found was that when you kind of get around that level of about 6,000 steps per day, that seemed to be the amount that had the most protective sort of capacity at reducing or preventing declines in function in people who had osteoarthritis or were at risk of developing osteoarthritis. So that's pretty lovely evidence to suggest that even when we do something like walking, it provides important benefits because you think about it, that's loading through the joint. That's helping nourish your cartilage. That's helping nourish almost your whole body, your mind. If you do it in nature, your mood. So I think all of these things, first of all, come with additional benefits. But this is just, I suppose, reassuring you that these small, what might seem to be small changes, on a broader scale, they add up to something big. So they're really important to do.
Excellent. And 1,000 steps, now for some that will be a lot, but it's kind of remarkable if you ever watch, when you look at it, you think, oh wow, God, I've only just been doing the housework and I've done 1,000 steps. It's often a manageable chunk for
Absolutely. And I
people.
think that's actually a really nice suggestion of, yeah, we often have our phones with us, or we have different watches, or you can even get those like little pedometers that you stick on your waistband. That can be a really interesting sort of detective activity, is to get an idea of how many steps you're doing per day, because that gives you an idea of how much or where you might want to place your goals. Because yeah, you're right. You might be surprised at actually how many steps you accrue just if going around the house.
Yeah, absolutely. It also reminds me of, we just off air, we're talking about our recent Flippin Pain tour, and one of the gentlemen that we had on our panel was a local Teesside gent who lives with arthritis in his spine, and he started. I mean, he was using a wheelchair for a lot of times to go out and about to the shops and things like that, and he was only able to do 2 or 3 steps,
Yeah.
and that was his lowest point. And he decided to use that, and he said, I remember him saying. I wanted to go outside of my comfort zone. Now, that wasn't easy to do because his comfort zone was, so close to home. So he went outside from his front door to the end of his driveway, 2 or 3 steps
Yeah.
and back, and he started there and built up. And now he's doing mountain holidays in Switzerland, in the mountains. You can read his story on our website on the Real Stories. It's Mac's story. But if somebody's at that point, is there still benefit in doing something so small because the benefits in the future will be so great?
Absolutely. And I think that is, it's just sometimes when we think about the big end goal, like let's say I want to be able to do X, Y, Z, that can become unmanageable and it can become too much. And when those goals feel too big, that's demotivating. So I think actually really thinking about, okay, what can I do today? And then just focusing on the subsequent todays can be a good way to start. So if we have this bigger goal, it can be really helpful to break it down into almost manageable chunks, little bits that when you get there, you're like, yes, I've done this. This is an achievement. I've made it there. I'm one step closer to my overall goal.
Excellent. Brilliant. We had a question come in on the webinars that we weren't sure of the answer off the top of our heads at the time, and that was about CBD oil, which we hear a lot about. A lot of people say, is it okay to take that as a supplement? Is there any evidence for it, that it might reduce pain in order to help people build up their physical activity?
Yeah, it's a wonderful question. And yes, I did. I went and did a bit of a deep dive into this area. And so basically, CBD, if anyone's not heard of it, it's a natural substance that they extract from the cannabis plant, and they often mix it with an oil, such as you often see coconut or hemp oil mixed with it. And then the important part, and well, I guess the part that sometimes it originally got stigma from is it actually doesn't contain any THC. And that's the component that's associated with the feeling of being high from sources like marijuana. So it is not that part. It's only the CBD part, and that's thought to target kind of different pathways that are involved with your feelings of pain and with inflammation. So at present, there's been animal studies that have looked at the effectiveness of CBD oils and different products, and they've shown that that has positive effects on reducing inflammation, and some positive reflects on what they call pain-like behaviors or threat defensive behaviors in animals. Um, The challenge being, of course, is that what we find in animal models doesn't always translate to human. And we see this a lot. But it suggests that there might be something there. So there has been some research looking at CBD in terms of nerve injury or something like it's often called neuropathic pain. But right now, there's not enough evidence that has been done in osteoarthritis or even arthritis more generally, or what we might term musculoskeletal pain. So things like low back pain, neck pain. There's not enough evidence to support its use. So I think there's been one study that I've seen that looks at the kind of topical or CBD oil, looking at its evidence for osteoarthritis and another type of arthritis called psoriatic arthritis. And they found in that study that the CBD was no more effective than placebo. But that's one trial. So I'd say at present, we don't have, and we do have anecdotal evidence. So some people will report that they felt that it's really helped, it's reduced pain, but we don't have good research evidence. And ultimately, that's what we have to base our recommendations on. So because there haven't been many trials done, it means that to really be able to give a full answer, we do have to test it. But right now, it's not recommended or by some of the bigger guideline organizations, such as NICE, that, for example, is UK. That's the National Institute for Health and Care Excellence. So I think at the present, it can be legally bought, CBD oil, as a food supplement in the UK from health food shops and some pharmacies, but it's not licensed as a medicine to use for arthritis. It doesn't, so some of the side effects that can occur with it is some people can report nausea, some dizziness, kind of just feeling a bit unwell. So we're not seen as serious side effects as things that you see from like more powerful anti-inflammatories, but it's still relevant to consider that the evidence, we don't quite have enough yet to really make a full recommendation on it.
Thank you very much. No. Excellent. It's sometimes good to go into the evidence in these things that people are using a lot, as you say, off the shelf, and sometimes it's surprising actually we haven't got that scientific evidence yet to support it.
Yeah, and lots of that is not related to us not wanting to test it.
Yeah.
Oftentimes if you speak to any researchers in this area, it can be really, really tough to get the funding to do those trials properly. And so some of that, we certainly are, when we see those gaps, we try to push and fill them. But that is often a large consideration for what might seem to be slow progress.
Fair enough. And one thing that had come up in our past webinars that I think is useful to go over again, and it's something that comes up in clinic as well, where you talked in the webinars about the phrase bone on bone. A question did come up at the time. Let's talk about it again. Can you grow back your cartilage? If you're looking at an X-ray where it looks like there's very little joint space left, maybe you've been told in the past it's bone on bone. We know that's not strictly accurate, but is it possible to improve your cartilage again?
Yeah, it's a great question. I would say that we don't fully know yet. So what we do know is we've got good evidence that when you load the joint, so when you do walk, you do exercise, do anything like that, that loading is actually essential for the cartilage health. So it is because your cartilage doesn't have a blood supply, it's loading that keeps providing nutrients that's coming from the fluid that's in your joint. So it's a really important aspect in terms of what we understand about the physiology of cartilage. In terms of the idea of bone on bone, it is important to point out that even if it looks like there's no cartilage left and things are touching, you still do have layers of cartilage there. So it's not gone. But so there has been, there's not been, me track back. There has been work that has shown, so they've monitored people who are at risk of developing knee osteoarthritis because they've undergone a specific surgical procedure that takes out some of the kind of big, thick cartilage called your meniscus. And so they followed people like that who had had the surgery, so that after the surgery, people are at risk of developing osteoarthritis. And what they did is people were either they either started to exercise, so they were randomized to exercise 3 times per week over 4 months, or they were randomized to no intervention at all. So they had the surgery and then they just recovered afterwards. And what they did is they actually looked at this very specific molecule, and it's called, I'm gonna mess it up. It is one of those tongue twister words, glycosaminoglycan. Woo!
Nice,
We're going to call
nice.
this GAG because that's much easier. So they looked at GAG, and that's actually a marker of cartilage health. And what they found was that the exercise group, they had an improvement in their GAG levels compared to the control group. And so, excuse me, when you don't have an intervention, when you're not moving, you're not exercising, you don't get an improvement in those levels. But when you do, actually your cartilage health improves. And what was really cool is they found a really strong association between how much that GAG content increased, so how much their increase in health occurred, as well with an increase in physical activity level. So people that were doing more physical activity, they had the greater improvements in cartilage health. So right away, that's actually really nice evidence to suggest that what's occurring within the cartilage you have, it's improving its health by moving. And this is even after you've undergone a surgical procedure for your knee. And to me, that's really exciting. If we look at some of the animal data, we start to see, a little bit more information about the effects of loading can have on cartilage. But kind of like I said before, what we see in animals often doesn't always translate to humans because there's a lot of different things going on. So I tend to probably put a little bit more weight into that human data.
Excellent. It reminded me, as we were talking there, of things like osteophytes or bony spurs that people might have heard that they have on their scans. And they sound pretty scary, don't they? They sound like pretty scary things. But would you mind talking a little bit about those things that crop up that sound terrifying?
Yeah. Well, I think one of the things that's really helpful to know that is when we have changes in any of our tissue, those changes typically occur because of something. And so oftentimes what we see in osteophytes is it's thought that what they're actually potentially doing is giving you a more stable platform. So when you slightly change the way that you load or you take force or pressure through a joint, that differing force or pressure, and this might be walking a bit different, it might be walking with a limp, it might be just changing how you're moving. Differences in force mean that your bone can remodel, it can change. So there's lots of evidence that show if you've had like a big surgery on your joint where they twist things around, the density of your bone changes and it remodels according to the pressure that's going through it. So many of those things that we see, they're often remodeling that, while they can be seen as really, really scary and like bad things, another way to really look at it is that they've given you this solid platform on which to base your movement. And so actually, oftentimes they can be helpful in increasing that feeling of almost a more stable joint. So it's almost a little bit thinking about them sometimes in a little bit different of a way. It's your body helping you out rather than a bad thing that's changing.
It's kind of amazing to think that we can adapt. I guess that's the whole hope of it all, isn't it? That's the whole
Absolutely.
message. We adapt to what we throw at it, our bodies. We just have to throw the right things at it and in the right doses.
Yeah,
No,
and I think
brilliant.
that is so cool because you think about bone, and for me, it seems so like set, like literally they're
Yeah,
bones, but they can adapt and they can change like that. It blows my mind still.
brilliant, brilliant. We had a question come in. I think is important. We talked in one of the webinars about, do we need a diagnosis from a healthcare professional for arthritis? We talked a little bit about how about that. So I believe that was on the first webinar. But somebody asked, if you haven't had it confirmed through a healthcare professional, how do you know which kind of arthritis you have? I wonder if you wouldn't mind kind of detailing the typical presentation of osteoarthritis, and maybe just a little
Sure.
bit about, if you haven't got that, maybe what you might need to see your GP about.
Sure. So oftentimes, osteoarthritis presents as joint pain that can occur at rest, can occur with movement, but that often isn't paired with very prolonged feelings of stiffness in the mornings. So it might be you have some stiffness that can change with the activity that you do. Like sometimes if you sit too long, it might get stiff, but it often improves when you move it. Or if you do too much, it can get stiff and improves when you rest it. All these different things, all of that falls under the category of osteoarthritis. And typically, we use also an age criteria. So if you're over 45, you have symptoms of knee pain and you don't have prolonged morning stiffness, that fits the clinical picture of osteoarthritis. And that's what the NICE guidelines that I referred to before, that's what they suggest as sort of the clinical criteria to diagnose osteoarthritis. And they suggest that when those things are present, having a scan often doesn't tell us too much extra, so it's not necessarily needed. There are situations, though, where you might find, and it is relevant probably to talk a little bit more to your GP, and that's when you have, really prolonged severe morning stiffness, and maybe ones that are affecting you bilaterally on both sides and in numerous joints. So it might be that it's both knees that are sore and super stiff, but actually also so are your hips and so are your wrists and so are your elbows. And those are situations where it might be something such as rheumatoid arthritis, which is typically associated with more distinct and higher levels of inflammation. And that often has a very different treatment course. Lots of the things are still similar in terms of like education and exercise is very good. But there are what they call disease-modifying anti-rheumatic drugs, or DMARDs, that can be used to treat some of that higher levels of inflammation. So I think if you're not sure, it's never bad to check in and see what type of arthritis you have. But what I would say is that for many cases, if you fit the picture of soreness in the joint and stiffness isn't sort of the main thing that's not going away in the morning, you're likely to fit this category of osteoarthritis and would very much benefit from slowly but surely increasing some of your activity levels and having to think about what type of foods that you're having in an aim to try to reduce these kind of body-wide low levels of inflammation.
Oh, yeah. Would you say it's the most common type of arthritis? I don't know the stats off the top of my head, osteoarthritis.
Yeah, it is. Yeah.
Excellent. We had a question emailed in, and it was a really, really great question. We talked in the past webinars about how we talk about our pain and how we perceive our pain. The way we think about it can have an impact on our future pain levels. And someone had emailed in and said, how do I talk differently to my family and friends about pain? Most often, this person is asked, how's your knee? That's the go-to question, and she'd love to be able to explain quite simply what she's trying to do, and she says, without boring people. Do you have any advice for this person?
Oh, what a great question. And I think it is a common challenge, isn't it? I mean, one of the ways that so I guess one feature that we often suggest is to possibly think of nice ways to challenge the words that people might be using about a certain body part. So if they're saying, your bad knee, then we might have like funny little ways that we might challenge it and be like, just exploring the aspect of how their words can actually influence what we feel as well. And that can be through a discussion, quite frankly, of saying, I know I really appreciate you asking about that. It's lovely to know that people are caring about me and wondering how I'm doing. I would like to ask if you wouldn't mind not calling it my bad knee, because I've actually found out some really interesting stuff that suggests that actually things like that can contribute to the way that I feel about it and the pain that I feel. Would you want to hear more about that? It's crazy. And that might be sort of one way into it, where we might then have a discussion of how actually there are many contributing factors to pain. So that there's all of these different areas that provide credible evidence of danger, and words and what we hear about our own body, that's actually one of them. And so, well, of course, it's not the driving cause of pain. It's all little things that add up. And so one metaphor that that Noy group uses a lot is this idea of the bilby in the bathtub. So bilby's a little cute little animal in Australia. But the idea is like, if we think about you sitting in the bathtub and the water's starting to get pretty high, and you've got all these other animals in the bathtub, you've got a moose, you've got a something else, and they're representing the different contributors to pain. So let's say it could be the moose is representing the fact that you do have changes in the joint. That's happened. Maybe another one's reflecting the inflammation that might be present. There might be another one that's reflecting actually the fact that you saw a really scary scan and it freaked you out. Well, appropriately, it freaked you out. And then you've got this little bilby that is what people around you are saying about your joint. And you've got this little bilby that dives into the bathtub. And of course, it all overflows. Now, it's not the bilby's fault, of course, but it highlights the aspect that there are multiple contributors to pain. So I think kind of finding those little unique, maybe metaphors or stories that we can use to actually practice how well we know our information and the education by actually telling it to other people. So I think that there's ways to kind of, I suppose, create it a bit like storytelling to get people's attention. But also, I think being really, I suppose, open with some of the different ways that you're dealing with it. And for many times, we find that it's saying, this is pretty new. This is not stuff that necessarily has been done forever. And I'd love to tell you a little bit more about this new stuff. And maybe it's because actually what you would like is you would like that person to be one of your safety in me's, one of those positive things that provide credible evidence of safety. And it could be kind of explaining that concept and saying, I really enjoy spending time with you. I'm starting to move more and walk more. Would you like to join me? And then we can kind of create this and embed some of those discussions into social aspects, as well as into fun stories that are actually, igniting curiosity. So I don't know that that's the best answer. And I think you'll need to it's a navigation to what feels right to you and for that relationship with that person. But I think there's a real opportunity to provide that information and for you to be a resource for your own family, because I am very doubtful that no one else in the family may have aches, not have aches and pains. So it could be very, very useful information for them as well.
Absolutely. And I guess they could share a resource like this, the webinar with their family and friends. It's a fascinating scenario because people of course are interested in how your knee pain is, because that's what they've always talked about to you, and you might start talking about your knee pain might actually be really helpful for you. But if you're starting to think, oh, this isn't, then that's a really useful way of approaching that. And I think most family and friends as well, they have the best intentions, don't they? They have your best interests at heart.
Yes.
So they're going to be glad to do something that would help. We hope. Same person with a second question. Very simply, how do I stay motivated? Which is a huge question, because of course we know that road to recovery is never a straight line. It's never a nice, easy route. Any advice for this person to stay motivated on that route to increasing physical activity?
Yeah, I think it is such a hard thing to do. And even for anything we do in our lives that can be hard or challenging, staying motivated is the key aspect and one of the most difficult things to do. I guess I would suggest a couple of different methods. The first being thinking about tactics. And so tactics are things that kind of you're purposely doing to reflect and show the progress that you've made. So as we were sort of just referring to, it's talking aloud about what you've learned and the steps that you're taking. And it can be just to yourself or it can be to other people around you. But I don't know, athletes do this all the time in terms of kind of sports psychology is like, this is what I've done. These are the things. It's reminding yourself of already the many steps that you've already taken. You can, as we kind of mentioned, explain what you learned to others. It solidifies what you know. But I think a key bit of this is you want to focus on your current effort and achievements rather than just that final goal, as we sort of referred to before. Because if we just think the final goal way far ahead, it can be demotivating because it seems too far. So it's focusing on those step to step. It also means things like valuing our own insights is actually really important. So it's thinking and reflecting upon your own thoughts and experiences. So, what have you done so far? How have you felt doing that? What about the one that's next to come? How are you feeling about the progress that you're going to make or what you're going to do? And that can just keep us really grounded within our experience that we're having. And then I also think to keep energy levels up, and that really probably is staying motivated, it can be finding a partner in crime. It can be finding someone else that's going through this journey and go through it together. It could be, finding people that give you energy. And that are happy to actually hear you talk about this journey that you're on. It can be when you have these kind of short and long-term goals and you're making steps toward them, properly relish in that achievement. Like really celebrate these steps. Like maybe you've got a month's goal and you make it to the end. Throw a party. Throw a party for your knee. That could be a really important thing to really say. Like, I have done this, because I think what's really hard is that it can be easy to not celebrate what we consider little wins, when actually that's actually critical to keeping motivation up. We do very similar things in research. Is we get so many rejections with everything, and we have these big projects, and then by the time you finish it, oh my gosh, I'm so tired of it, I don't even want to celebrate. Nah, you've got to celebrate those wins along the way so that actually you stay motivated towards that goal. And I think when you have in your mind a clear plan about what you want to do, that does make it easier to stay motivated, because you will have those individual steps that you have planned that then you can reflect upon, you can celebrate. And I think just feeling that you're doing these things purposefully and you're doing these things yourself, like you're taking control of your life, of what's going on. This is a big you thing. And I think for me personally, I find that really quite motivating, knowing that what I'm doing is purposeful and it's something that I'm doing. That's quite empowering, I think. So those are kind of a little bit all over the place tips and strategies, but I do think it's multifaceted. I do not think it's one thing that keeps our motivation up, and it's us sort of checking in and seeing where we're feeling. And when we don't feel very motivated, going to that, having that person or that event, that walk in nature, something that really brings us back to feeling like we want to do it.
Brilliant. I think we're not good at celebrating our successes, are we? We're
We
not
are
even good at
not.
celebrating the big things, all the small things, and I think that's brilliant. And going back to the previous question from the same person, it brings those people back in, and it shows them how important this is to you and how much you want to move forward. So absolutely, yeah, I'm all for throwing your knee a party. Not enough reasons to celebrate. Let's do it. Brilliant. Thank you very much for that, Tasha. That was the questions that we didn't get a chance to answer. We also spoke at the beginning about how we were going to discuss some of your more recent research. So you are really at the forefront of arthritis research. This is I'm excited to hear this. So yeah, if you wouldn't mind sharing a bit about perceptual dysfunction, I believe.
Yeah. So this is an area that, like, actually I've just been intrigued with for quite some time, because when I was working as a physio, I worked with a fair number of people who had painful knee osteoarthritis, as well as people who had undergone surgery for different things. And there was often a group of people that would report that their knee just, or their joint or limb didn't feel right to them. Like they really had to pay attention when they were moving it. They weren't very sure where it was located in space. Yeah, it maybe felt wrong to them, like too big. It felt like it was swollen, even though it wasn't. And so that kind of just got me down this route of trying to understand what that is, what's going on there. And so not everyone may have experienced this, but you might have had feelings where it's like you're more likely to trip with that leg or stub your toe on the side that you have a sore knee or a sore hip. Um, and those are kind of little things that maybe there might be something going on in terms of how your brain is processing the incoming sensory information from your limb and what it's doing to use with that information. And so some of my work showed was that people with osteoarthritis, and this is people with painful knee osteoarthritis, they weren't as good at localizing touch. So if we touched them on the skin with 2 points and they had to tell us whether it was 2 point or 1 point, and always at a certain level for all of us, even though we're touching you with 2 points, it feels like 1. And that gives you sort of a measure of the precision of how touch information is represented in your brain. And we found that it was less precise. So the information coming from touch, it's not telling people with knee osteoarthritis as precise of information as it is for people who don't have knee osteoarthritis. And similarly, we found that some of the brain maps that help us coordinate and plan different movements, they don't seem to be working quite as well. So this kind of suggests that information from touch and from your proprioceptive sense, so your ability to know where your limb is located in space, it doesn't seem to be as precise, meaning that maybe that makes sense why we're more likely to feel like we're tripping or not knowing where our limb is located in space. And the reason that I was quite interested in those is because actually, if in other conditions, chronic pain conditions, if we train those different senses, train touch, train proprioception, oftentimes pain reduces. So it kind of raises the possibility that these might be new potential treatments for people with osteoarthritis and that don't involve drugs. They don't involve invasive surgery. They involve actually training how good our senses are working so that it can sort of better give you information about your joint or your limb. And then we also that's sort of you're not aware that those things really are different the way that we tested them. So we also developed a questionnaire that helped us explore kind of the awareness of your knee, and it included items like, how often does it feel like your knee is not really the part of it doesn't feel like it's part of your body, or how much attention do you need to focus on your knee? And my knee feels like it's bigger or swollen. And so that gives us almost a score of how frequently people feel these different kind of weird sensations about their knee. And we found that this score seems to matter. So, for example, people with higher scores on this questionnaire suggesting that there might be more changes to how this sensory information is being processed in the brain. We found that the higher scores on this are related actually to higher clinical impairment, so higher pain levels. It's related to higher disability, higher fear of movement and anxiety. So this made us sort of think, well, maybe this matters. So we took a look and we had the scores that they had on this questionnaire, and we had people undergo an exercise program. So they had 20 minutes, 2 or 3 times a week, over 3 months. And this was lower limb stretching and strengthening exercises that was supervised by a physiotherapist. And we found that people that had higher scores on this questionnaire, so suggesting the sensory processing doesn't seem to be as precise potentially for this from that body part. Those with those, I guess we might call higher levels of body perception disruption, they did less well with exercise. So 80% of them were non-responders to exercise, so they didn't have a large reduction in their pain. So it suggests that this might matter. Like maybe if we're not really sure where our limb is located and we're undertaking exercise, maybe it makes us less able to engage in exercise programs. We don't really know. But then we also explored if this might have a role in people who have undergone a total knee replacement surgery, and they've unfortunately developed persisting pain after that surgery. So what we did is we took a sample of people that were undergoing surgery for their knee, and we followed them over time. And we used this questionnaire at baseline to look at kind of levels of perceptual impairment. And we actually found that their baseline level of this perceptual impairment, it didn't predict necessarily who developed pain, but in the people that developed this persisting pain after surgery, they did not have an improvement in this perceptual dysfunction, or this perception of their body. So almost it very, very slowly changed a little bit, but they still had very high levels of this, which actually suggests that maybe this perceptual dysfunction or this change in body awareness might be contributing or playing a role to surgical outcome. And so again, many of these things, we might be able to target these kind of body awareness changes with various treatments that don't involve drugs and don't involve another surgery. And so, yeah, we're really excited to see if some of these things might have really nice effects on either helping pain or potentially preventing post-surgical pain from occurring after surgery. So all of this stuff is super new, but it's things that I guess we're really interested in exploring because like I just have such a thing for, I want to look at aspects that we don't necessarily have to go back in and operate again, because it's hard for people to undergo those surgeries. It's stressful. Like, what can we do? We got to understand this more. So yes, that is 10 years of research in about 5 minutes.
No, that is fascinating, and I appreciate. I've got some questions, and I appreciate, as you say, this is new stuff, so you may not have the answers yet. The answer may be in a few years' time. But if are you kind of saying, even if you're speculating at this point, do you think that somebody who's got these symptoms, who's like, yeah, I feel clumsy on that leg, I feel like it feels much bigger than it is, etc., that they might not respond as well to physical activity? Or do you think that they might not respond as well to physical activity until that joint positional sense is treated and improved?
Yeah, great question. I think it's actually probably two things. I think, and based on the data that we have, I think that they will respond to physical activity, but it will be slower. So although that when I was talking about, 80% were non-responders, we were pretty strict with our criteria. Like they had to have a 50% reduction in pain. So it's a really big change in their pain. So they still did have some reduction, but it just suggests that that might take longer. But it does not exclude the possibility that if we target that first, they might have a similar trajectory as people that we don't see this. And it is important to point out that in that study, we didn't have a control group. So we just had the people undergoing exercise, which means that some of those changes over time, they just occur naturally as we often see what is a technical term called regression to the mean. So often we get people that come into trials when their pain is quite bad at the start, but it would settle down anyway. So we do need to do more work to really understand that a bit more. But to me, it raises such an interesting question because we don't know. But if we start to look at that and see what targeting that early has, that could be really helpful. Because I don't know about you, but if I start walking and doing things and I'm not seeing improvement, I'm going to think that's not working for me, right? So trying to motivate and convince someone to keep going, even though they're not seeing improvement, just because their trajectory is going to be less fast, that's actually a real barrier. So to me, it raises a really important question to follow up on.
Excellent. And you mentioned that there may be treatments that don't involve surgery. Would you mind just kind of share a little bit about what that might look like in the future if we were treating this sort of thing?
Yeah, of course. So there are some that are a little bit more established that's called tactile discrimination training, where what you're trying to do is just determining where you're being touched on a limb. So you have lots of different points. We give different type of stimuli. So it might be, the pointy end of a pencil versus the eraser end. And so you have to say, point one. You touched point one and it was dull. So, but it's requiring you, I suppose, to attend to that area and discriminate very distinctly where you're being touched. And we know different training like that can help refine some of the maps that you hold regarding touch in your brain. So that one is one that has been used before in other conditions. Another treatment, and it's actually, people may have heard of it or aspects of it, and that's graded motor imagery that is used for often conditions like complex regional pain syndrome. But some of the stages of graded motor imagery, they may be relevant in doing. So particularly the first stage is where you're doing what are called left-right judgments, where you see an image of a body part and you have to determine whether it's a left or a right body part. And based on brain imaging studies, we know that when you're making these decisions, you're actually needing to mentally maneuver your own kind of virtual limb into that posture of what you see. So you need to use your brain maps that plan and coordinate movement. So if you practice that task, that can be helpful to try to train, retrain and improve some of those brain maps. It might also be proprioceptive type training where we can move a joint in a certain direction or a certain amount, and we have to get you to tell us how much it moved and what direction, or doing different matching tasks to try to match this one, and then you close your eyes and you have to do your best to match the same angle, and it's practicing precision in these different movements. There's also, in terms of, we do see some evidence to suggest that if we give people a picture of their own knee, people with osteoarthritis will choose a knee that's larger than their actual knee size. And this might be something that we can target. We have done we call them body illusions, where we use a technology called mediated reality, and it involves real-time video. So you see your own body in front of your eyes, you can move it around, know it's yours, but then with a computer program, we manipulate what you see. So we can make your knee look big and stretched out, almost like nice and tractioned and elongated. And we found that was reduced people's pain. So one illusion reduced their pain by 20%. And if we repeated it 10 times, it reduced pain by 40%. So some of these things, these weird things where we're, manipulating how a body looks to you, they actually have links. We know that you have links between your different senses, and it seems to matter to the pain you feel. So kind of all of those things are ways that we could start to explore this as a treatment to target changes in body awareness or perception.
Brilliant. So what I'm thinking is, if somebody is thinking, that's me, this sounds like me, those sound like there are things there that they could take to their physiotherapist, like graded motor imagery, to work on. And I wondered if the questionnaire that you mentioned, is that out now for healthcare professionals to use, or is that yet to be published?
Yeah, no, it's out. And I'm very happy to share a version of it. It was originally created actually for back pain. So there's I think there's a back version, a knee version, and there may be a shoulder version as well, because it's actually very similar type things. It's almost, it comes actually from the stroke literature. So the idea of neglect, where suddenly you don't pay attention to one side or one part of your body. And this isn't neglect. It's not anything like that, but it has items that capture those similar things. I'm very happy to share those. And yeah, I think they're interesting things because all of us feel some of this sometimes. So if you feel this, don't feel worried that something's wrong with you, that you're, oh my gosh, I'm never going to respond, I'm not going to do well with exercise. No, that's not the case at all. Because remember, even in the study that I was talking about where we had people exercise, 20% of people that did have these higher levels of perception dysfunction they still did really well with exercise. So it's not a be all end all. It's not a bad thing. But what it helps us to do is just to better understand each individual's experience, because that's the thing. We all know this. Every single person is different. And so the more questionnaires or tests or techniques that we have to better describe your picture, the better that we can make hypotheses and guide where we might want to try our treatment. So please don't feel alarmed or worried if you think that fits you, but rather think, I might have another opportunity for improving. So it's just part of the picture.
Brilliant, brilliant. Thank you very much, Tasha. And that brings us to the end. So thank you very much again, as I say, to Tasha. Thanks to everyone who's watching. And before you stop the video, I would like to draw your attention to the survey that you'll find. If you're watching this on YouTube, there'll be a link in just underneath this. And if you're watching it on our website, it's under the thumbnail of our video. That is a link to the survey that is still open. So as you can imagine, we do what we do because we hear back from you guys about what works and what doesn't. So it really helps us as well get the funding for these sort of events and make our future events even better. If you can tell us what you enjoyed and what we can do better. So if you can fill in that survey, we'd much appreciate that. If you've enjoyed this series of webinars and you've gained something from it, let us know. We're at info@flippinpain.co.uk. It's Flippin without the G, as you can see there. And you can also get us on social media at Flippin Pain. I must thank Haywood, Middleton and Rochdale Integrated Care Partnership for all their support for these series of webinars. And huge thanks to Associate Professor Tasha Stanton. And thanks everyone for watching. Thanks again. Bye-bye.